Good evening and welcome to IMED Radiology's webinar for cardiac functional imaging, understanding and referring nuclear medicine and echocardiography. My name is Rick and I'm the Sales and Marketing Manager for Queensland and the Northern Territory. Firstly, I would like to welcome all of our participants to the second webinar in our cardiac series. If you missed the first webinar, Getting to the Heart of It, you can catch up on this via our website by visiting i-med.com.au. With coronary heart disease being the leading cause of disease burden and death in Australia, it is vitally important that we discuss these topics and how IMED can collaborate with our referring partners for best patient outcomes. At IMED Radiology, we have a vision to be the most respected and trusted medical imaging specialists in the world. This vision is underpinned by our purpose, which is to save lives and reduce uncertainty. We aim to deliver the best possible patient experience and outcomes through initiatives such as e-referral and online appointments. E-referral enables you, the practitioner, to send a request for imaging directly to us. The patient receives a link to their mobile device, which allows them to either book their radiology appointment online or request contact from our customer service team. It's convenient, it's safe, it's secure, and patients who use e-referrals book their appointments 4 times faster than standard methods. This results in a streamlined process, which brings the patient back to you for prompt clinical follow-up. If you would like any more information on gaining access to e-referral, please visit our website at i-med.com.au or speak directly to your IMED account manager. Without further ado, I would like to introduce you to tonight's facilitator, Dr. Philip Pearlstein. In 1988, Dr. Pearlstein founded Midtown Medical Clinic in Melbourne and followed this by co-founding the Melbourne Sports Medicine Centre in 1993. He has served for several years on the Victorian Panel of Examiners for the Postgraduate Fellowship of the RACGP and has been a member of the selection panel for Monash medical students. Today, Dr. Pearlstein remains active with both his founding practices, primarily in a management and mentoring role. Before I hand over to Dr. Pearlstein, I do have one last housekeeping item to mention. At the conclusion of the webinar, can we please ask that you stay online to complete an evaluation form? Your feedback is important to us as it allows us to continue to improve these education sessions. As we are focused on keeping these as relevant and informative as possible, suggestions for content for future webinars and also feedback in general is very important to us. I will now hand over to Dr. Pearlstein to introduce our guest speakers.
Thanks, Rick. Good evening, everyone, and welcome to this IMED webinar focusing on cardiac functional imaging with nuclear medicine and echocardiography. It's great to see so many of my GP colleagues attending. As you'll all know, and as we discussed at the last IMED cardiology webinar, which was dealing with cardiac CT, heart disease is still very common in our community. Hence, the knowledge of cardiac investigations is essential to our everyday practice. We're very fortunate to have 2 prominent experts to lead this discussion this evening. Please feel free to ask any questions during the presentations. Just use the blue hand icon to enter your question. I will monitor the questions during the presentations and will attempt to have as many as possible answered during the Q&A after the second presentation. There'll also be 2 poll questions during each presentation. I think these are designed to ensure that none of us is dozing after a busy day. Our first speaker is Dr. Peter Bortz. Dr. Bortz is a cardiologist at Griffith Base Hospital and St Vincent's Private Hospital in Sydney. He has a keen interest in early detection of coronary artery disease and other cardiac conditions, including heart failure, valvular heart disease, and arrhythmia. Cardiac imaging is his main specialty, with extensive experience in cardiac CT reporting, echocardiography, stress echocardiography, and transesophageal echocardiography. Thanks very much, Peter, for joining us with your presentation this evening.
Good evening. Thank you to everybody for attending tonight's IMED symposium, and thank you to Sue for inviting me to speak. Tonight's topic is cardiac imaging, and I've been asked to speak mainly about stress echocardiography, benefits and limitations. I will be including clinical parameters to allow us to identify the best place for stress echocardiography. So the current cardiac imaging, there's an array of imaging that we have at our disposal. The first two I feel are underutilized in ECG and chest X-ray. ECG should be the first tool, followed by the chest X-ray. CT coronary angiography has been around for about 10 to 15 years and is a highly sensitive tool for diagnosing coronary artery disease. I'm going to speak a little bit more about this later in the talk. Then echocardiography and stress echocardiography are easily available, non-invasive tools that give us real-time information without any post-processing. These two modalities can tell us immediately if there is a problem structurally with the heart. MIBI and stress are going to be spoken about by Professor Rick McLean, and I look forward to hearing his views. And I'm not going to be speaking about TOE, MRI, or PET scanning. So the objectives of the presentation is really an overview of stress echocardiography, comparing this with other testing for coronary artery disease, the benefits in addition to testing for coronary artery disease that echo provides us, and then some of the limitations of stress echocardiography. I thought this was a very interesting slide outlining the average daily deaths in the US from COVID in January 2021, showing that it was the leading cause of death. But the reason I used this slide is to highlight that heart disease was the second biggest cause of death, followed by cancer, just highlighting the importance of trying to reduce the cardiovascular or heart disease burden on the population. Now, this is an interesting slide from 2012 from the New England Journal of Medicine, published by Braunwald, showing how over time, as further development in imaging devices, drugs, and testing, how the incidence of deaths has decreased over time. For example, the first open heart procedure was in 1954, coronary care unit in 1961, coronary angioplasty in 1979, thrombolytic therapy in 1986, left ventricular assist devices in 2009. And with all these major developments, we can see how we've managed to decrease the deaths per 100,000 in the population. Now, my view is, how are we going to be able to decrease this further? And I think this is where CT coronary angiography is starting to show promise by diagnosing subclinical atherosclerosis, treating risk factors, and putting patients on statin and aspirin therapy at an earlier time than prior. And I'll talk a little bit more about that later on. So this is one of the take-home slides of my talk. It is very important to know about subclinical atherosclerosis because 68% of myocardial infarctions occur on soft or vulnerable plaques with a stenosis of less than 50%. This is very important when we discuss stress echocardiography and stress ECG testing, because these modalities cannot pick up disease unless the stenosis is in excess of 80 or sometimes 90%. Furthermore, the probability of dying from cardiovascular disease is 47% in the Western world versus 22% of dying of cancer. And the lifetime risk of a 40-year-old male developing coronary artery disease is nearly 1 in 2, and females 1 in 3. So very, very prevalent disease. Now, this is my approach to the diagnosis of coronary artery disease. I think CT angiography in a patient you suspect of having coronary artery disease should be your first test. If the study is normal, it is a very sensitive test. It is almost impossible to miss disease. And if it is normal, we can provide reassurance. If there is mild disease, non-obstructive, minimal plaque, low calcium score, medical treatment can be initiated early. If the disease is moderate and we are not sure whether this is functionally significant or could cause ischemia, that is where functional testing, for example, stress echocardiography, stress ECG testing, or SPECT MIBI testing is appropriate. If the disease on CT angiography is severe, we have the opportunity or the option to go straight to invasive angiography with a view to revascularization. This is a slide comparing the sensitivity and specificity of exercise ECG, SPECT or MIBI testing versus stress echo. We can see that stress ECG only has a sensitivity of 68%, which means that even if you do have significant disease, stress ECG could miss up to 1/3 of people, and in some studies up to 1/2 of people. If you combine that with a nuclear agent, the sensitivity improves dramatically up to 88%, whereas stress echo, the sensitivity is 76%, can still miss up to 20 to 25% of cases. If you do have a positive exercise ECG, it is reasonably specific for coronary artery disease. If you have a positive stress echo, it is very specific for coronary artery disease, less so for SPECT or MIBI. Whereas the sensitivity of CTCA for detecting coronary artery disease is in the region of 99%. This is not charted on the slide. So here we arrive at our first poll question for the evening, and that is true or false. Stress echo has a higher sensitivity for diagnosing coronary artery disease than CTCA. I'll give you a few minutes, a few seconds to ponder that question. And the answer is obviously false. And if we go back to the slide, as I mentioned earlier, stress echo sensitivity is 76%, whereas as I mentioned earlier, CTCA has a sensitivity of close to 100% for diagnosing coronary artery disease. I'd like to talk a little bit more about the technique of stress echo. So the patient would have a full echocardiogram before the test to check for structural heart disease, valvular heart disease, previous myocardial infarction, LV dysfunction, etc. We then take 4 pre-echo pictures: parasternal long axis, top left-hand corner, parasternal short axis, bottom left-hand corner. We do a 4-chamber view from the apex and a 2-chamber view from the apex. And then we compare these 4 pictures before to after exercise when the patient has a tachycardia. A normal test is all left ventricular segments contract vigorously post-exercise and the left ventricle becomes smaller. That would be a normal response. A positive test would be that an area of the ventricle is hypocontractile or sometimes doesn't contract at all. that would be indicative of a positive test. And sometimes the ECG does not show ischemia, but the stress echo pictures are positive. And that is why the stress echo is more sensitive than stress ECG. Contrast echocardiography is not used widely in Australia, but it does improve the specificity of stress echo. Now, here we have a slide outlining territories that correspond to coronary arteries. So we do have some idea of if a certain area of the ventricle is hypocontractile post-exercise, that it is in keeping with one of the three major arteries. So if we just focus on the dark blue vessel, that's the right coronary artery. If we look at the top left-hand picture, the four-chamber view, we can see where the area of the right coronary artery is depicted. Same with the short axis view below that, and in the two-chamber view. So by using all four views, if we do get a positive test, we can have a reasonably good idea of which artery is involved. If there is an increase in LV size and significant hypocontractility in all areas, that could be indicative of either left main disease or triple vessel disease. And then we have wall motion scoring as depicted in the left bottom corner, 1 to 5, 1 being normal, 5 being aneurysmal dilatation. Now, as I mentioned earlier, stress echo is an immediate test. It's happening real time. There's no post-processing. And this is where stress echo does have the advantage over other modalities when assessing for coronary artery disease. When you put the probe on the chest before, you can see immediately if there is structural heart disease. In the left-hand picture, we can see prolapse or caudal rupture of the anterior leaflet of the mitral valve, which in the right-hand picture shows severe mitral regurgitation. So this would obviously give us the diagnosis before we went on to stress echo, and the patient would need to be assessed for mitral valve replacement. The other modalities, for example, stress ECG, SPECT or MIBI, CTCA, do not have the benefit of the echo in picking up structural heart disease even before the test begins. Now, what can we tell the patient who has a normal stress echo? How at risk is he or she of having an event? And it turns out that if you do have a normal stress echo, your cumulative survival percentage is pretty good for the first 2 to 4 years, with very few cardiac events. However, I must stipulate that this has got to be a patient who can exercise to at least 10 or 12 metabolic equivalents, or at least to a heart rate of 85% of their maximum age predicted rate. So it might mean that we are already dealing with a fitter or healthier population. Once your treadmill test or stress echo shows ischemia, you can see your cumulative survival starts to deteriorate. So it is still prognostically relevant, but as I must have mentioned many times, we cannot exclude or diagnose subclinical atherosclerosis. So a patient may have a calcium score of over 1,000, have a lot of soft plaque, hard plaque, left main disease. If it's not causing ischemia, stress echo will not pick it up. So what some people are doing is doing a calcium score as well as a stress echo. The problem with that is if you're not doing the full CT coronary angiogram, you could miss soft plaque in people in the 45 to 55 year age group or 45 to 60 year age group in females. So very important that we explain to our patients that a normal stress echo is not indicative of normal coronary arteries. So this is a repeat of what I said earlier. There was a study done in diabetic patients in America, published in the American Journal of Cardiology. 563 patients had a normal stress echocardiogram, predicted the absence of any cardiac event for up to 2 years, with an annual cardiac event rate of 0.6% per year over a 3-year follow-up. So normal stress echo, if you achieve all the parameters of a normal test and you've got the body habitus and you've got good pictures, you can still use that as a predictor of cardiac events. What are the limitations of stress echocardiography? So depending on the patient's body habitus, you can get suboptimal image quality in about 10 to 15% of patients. Patients with chronic obstructive pulmonary disease, hyperinflated chests, can be very difficult to visualize the myocardium, the endocardium, etc. If you have an inadequate heart rate response because the patient's got a sore leg, is unfit, can't get the heart rate up, that limits the ability of stress echocardiography to be sensitive or specific. We do get false positive tests in patients with severe hypertension, because when a patient's blood pressure on the treadmill goes up to 200 or 220, this can affect the left ventricle contractility. We think it's because of ischemia, but it's because of poorly controlled blood pressure. And it is well known that stress ECG and stress echo is more commonly falsely positive in females. I mentioned ECG earlier. If you have a left bundle branch block at rest, you will already have a wall motion abnormality when assessing the ventricle, and therefore analyzing the ventricle post-exercise becomes very limiting. And finally, the test is only positive if there is a significant stenosis, upwards of 80%, in some studies even 90%, and therefore we cannot detect subclinical atherosclerosis. This is very important because studies are showing now that if your calcium score is above 100, being on aspirin and statin therapy can produce better outcomes from a morbidity and mortality point of view than if you leave these patients with high calcium scores without treatment and without significant follow-up and intervention to other risk factors. Example, smoking, diabetes, hypertension. These other risk factors need to be treated aggressively. And it has been well shown that if you show a patient that they've already got high calcium on their arteries, they tend to be much more responsive and compliant with medications. Poll question number 2. True or false? You can visualize coronary calcium with echocardiography. Obviously, the answer to this is also false. It would be an amazing echocardiogram if we could pick up calcium on the coronary arteries, but only CT coronary angiography or a calcium score can pick up calcium on the arteries. which is a very strong predictor of future events, as was detailed in Dr. Ken Cecil's talk a few months ago. What are the added benefits of stress echocardiography versus the other modalities? Well, it is a non-invasive test. There are a lot of people who are worried about radiation with CT scanning, and echocardiography is non-invasive. There's no contrast, there's no cannula, there's a little bit of gel and a probe on the chest, that's all. In addition to it being non-invasive, it is excellent at diagnosing structural cardiac disease. And here are a few examples. Hypertrophic cardiomyopathy. You wouldn't want to exercise someone if they had significant hypertrophic cardiomyopathy with an outflow tract gradient. Valvular heart disease, I mentioned in an earlier slide. Sarcoidosis, pericardial disease, a pericardial effusion. All these diagnoses can be made quickly and easily prior to the stress test. We can also get an accurate assessment of LV function at rest very quickly and very easily. And then dobutamine stress echo can detect hibernating myocardium, which can allow you to predict whether patients will benefit from revascularization. And that is the end of my talk. I thank you all for listening and look forward to question time.
Thanks very much, Peter, for that informative discussion. For those of you that are wondering, seeing me live is you're lucky because I've got a few technical issues at home for some reason, so apologies for that. Now we'll have questions for Peter after the next presentation, so keep them coming in, and thank you for those that have already posed them by hitting the little blue hand on the screen. I'm pleased to be able to introduce our second speaker, Professor Rick McLean. Professor McLean has worked as a nuclear medicine specialist at IMED Radiology since 2008. He graduated from the University of Sydney in 1978, then trained through the Royal Australian College of Physicians, completing subspecialty training in nuclear medicine and undertaking a fellowship here at Princess Margaret Hospital. He's been an active member of the Australian and New Zealand Association of Physicians Nuclear Medicine, including as its president, and also the Royal Australian College of Physicians. So thanks, Rick, for your presentation. Over to you.
Thank you for the introduction, Philip. I'm going to talk about myocardial perfusion imaging. Firstly, a couple of nuclear medicine principles, which I'm sure you're probably aware of. But firstly, that nuclear medicine is a physiological imaging procedure rather than an anatomical imaging procedure like a non-contrast CT or an X-ray. You can do a CT scan or an X-ray on a dead person, but you can't do a nuclear scan on a dead person. Have to be alive, and it's physiological. The study uses a radio tracer and a gamma camera. Now, the radio tracer, there are two parts of the radioactive tracer. One is the radioactive substance, which is attached to a chemical that is a tracer, and it's called a tracer because it goes to a particular organ depending on its chemical characteristics. Once it goes to that organ, we take a picture of it with a thing called a gamma camera, which is basically a very sophisticated Geiger counter. So it'll just basically detect where the radioactivity is. The tracer that we use is technetium-99m sestamib or technetium-99m tetraphosmin. They're just the two tracers, and it's because the first one that was used was called sestamib, that's why it's quite often called a MIBI scan, but we use both. The way that this tracer works is it is taken up by functioning living myocytes, and myocytes that are not functioning because they're ischemic or dead don't take up the tracer. The procedure has several parts. Firstly, there is an injection at rest, followed by a rest scan. Then there is a stress test with the injection performed at peak stressing. And then the second scan is performed, which is the stress scan. And we always compare the two, the rest scan and the stress scan, and that will become, the reason for that will become apparent later. The stress testing procedure that we use, previously we used to use either a standard treadmill or bicycle to achieve 85% predicted maximum heart rate, which is what's needed to make sure the test is accurate. Now the stress test like that is primarily used in rural locations where stress echocardiography is not available or has limited availability. Now we nearly always use pharmacological stress testing as a result of MBS changes to the Medicare benefit schedule last year, which were quite strict. And it basically, this is a quote from the Medicare benefit schedule, and it basically says that you can do the myocardial perfusion scan if the person has a body habitus or other conditions so that stress echocardiography wouldn't work. If the person tried to have stress echocardiography or was unable to exercise to the extent where stress echocardiography provided an adequate result, or if for whatever other reason stress echocardiography failed. Pharmacological stressing is carried out using adenosine or dipritamol, and these are two chemical agents whose, while they have other actions, their primary role for the purpose of the myocardial perfusion scan is to cause coronary vasodilatation. So normal vessels, non-stenotic vessels, can dilate and increase the blood flow. So the stenotic vessels aren't, because they have a stenosis, they can't dilate in the same way. So what you get is relatively lesser blood flow and therefore relatively lesser tracer delivery in abnormal vessels, which can be either as a result of, which can either be due to infarct or ischemia. The side effects are relatively mild, although most people do feel a little bit funny, but it's a very transient thing and wears off as soon as the infusion is stopped. So the side effect one is hypotension, and the other one can be bronchoconstriction. And that is particularly of significance in someone who has underlying COPD, where the bronchoconstriction they get might be the straw in the camel's back. If someone does have severe COPD, we will use dobutamine instead, and dobutamine simply increases the heart rate and blood pressure as exercise does. People are concerned about the radiation dose. It's around 10 millisieverts. You don't need to know too much about what millisieverts are, but for reference, a chest X-ray gives you about 0.1 millisievert, and that's often considered sort of the a baseline. This gives 10 millisieverts, and that's roughly similar to what you get from a CT abdo-pelvis without contrast. So the reasons for doing the myocardial perfusion scan, firstly, in suspected coronary artery disease. And the reasons there are, if the initial testing has not been possible. For example, if someone is quite elderly, they mightn't be able to do a stress test. If they have arthritis or peripheral vascular disease, if they have an underlying conduction abnormality, particularly left bundle branch block, which will cause the stress echo to be abnormal anyhow. If they have severe COPD, or increasingly body habitus with someone being obese and therefore possibly not being able to exercise, or if they try a stress echo, they might have a poor stress window. If stress testing has been performed and it's inconclusive, in other words, if they don't get to 85% of the maximum heart rate, or sometimes if there's an intermediate probability after they've had the initial testing, so for example, pain but no ECG or wall motion change, or if there has been an ECG change but or wall motion abnormality change, but the person hasn't got any pain, you're sort of left sitting on the fence a bit. In the case of known coronary artery disease, it's primarily for detection of in-stent restenosis or graft stenosis, because the stress echo might be a little bit more problematic in those situations. If someone has a number of lesions, you can determine which is the culprit lesion, which is the one that has the most effect, or if there's a lesion that might be of borderline significance, is this functionally significant or not? The test is done quite often preoperatively, particularly by the vascular surgeons, who know that the person has vascular disease somewhere and they want to make sure they don't have vascular disease somewhere else that might cause a complication operatively. And in hospital situations, it's used sometimes for triaging hospital patients with chest pain who might have ECG changes or a small troponin rise, which might be a type 2 NSTEMI rather than a true infarct, because the adenosine doesn't cause coronary vasodilatation, so it doesn't cause ischemia, and the person can then be triaged and probably get out of hospital quite promptly if they're not able to undergo other testing in hospital. Now we have to go briefly to statistics, which I'm sure you all love. When you have a new test, to work out how accurate the test is, you need to compare it against a gold standard. And for myocardial perfusion scanning, the gold standard has always been coronary angiography. And you would be aware of the two primary terms, the sensitivity and the specificity. That's, as you know, that's the proportion with the condition or with the gold standard condition who have a positive test, while the specificity is those without the condition who have a negative test. Having said that, then the gold standard may not always be perfect. And for those of you who've seen coronary angiography, to make a on-the-run call between a 60% non-significant lesion and a 70% lesion can sometimes be pretty tricky. What's more important to you as clinicians out there practicing is not so much the sensitivity and specificity, while they are important, but more the predictive values. So you want to know that if someone has a test and they have a positive result, do they have the condition? And that's called the positive predictive value. While the negative predictive value is those people who have a negative result who do not have the condition. So they're the two important things. Now, the prevalence of the condition in the population tested, or what we also call the pre-test probability, will alter the predictive values independent of the sensitivity and specificity. Now, that might seem a bit strange, but I'll show you in the next couple of tables how that actually works. Here, let's take a condition, some disease, any disease, and let's just say its prevalence in the community is 50%. So if you do a test, you'd have 100 tested 200 people, you'd theoretically have 100 people who have it and 100 people who don't have it. Now, when you do the test, if the test is positive in 90 and negative in 10, that means your sensitivity is 90 over 100, so 90%. If your test is 90% sensitive, of those who have the test, 90% will have a negative result and not have the disease, but you'll still get 10% of tests that are positive, but that will give you a 90% specificity. Now, as I said, we need to go the other way when we're looking at positive and negative predictive value. So here we have people who have in this population, if we put in that sensitivity and specificity, you'll have 100 people will have a positive result, but only 90 of them will actually have the disease. So this gives a positive predictive value of 90. On the other hand, we will have 90 people who have a negative result, but 10 of those will be false negatives. So our negative predictive value here is 90%, but however, this is a very artificial situation to have a test that's 90% positive, 90% specific and sensitive. That rarely happens in real life. And it's uncommon to get a prevalence of 50% of any disease in the community, but I'm just showing you that to show you how these numbers work. Let's go along to a condition that is much less prevalent. Say it's 9%, and these numbers are here just for to make it easy for calculations. So if we have a sensitivity of a test once again that is 90%, we'll say in those who have the disease, they'll have a positive result, 90. A mistake. They will have a positive result, 90 out of 100, and 10 will be negative. Of the 1,000 people, if we still have this specificity of 90%, we'll have the test being negative in 900 and positive in 100. So in this situation, with a lower prevalence, we still have the sensitivity and specificity of the test at 90%. However, if we now look at the results, which is what's important to you, Here we can see that these numbers will give us that there is 190 people who have the disease, but only 90 of them will have a positive result. Or at least 90 of the 100, I'll say that again, 190 people will have a positive result, but only 90 people will have the disease. So that drops the positive predictive value to 47%. On the other hand, here we have 910 people who have a negative test result, and 900 of those don't have disease. So that raises the positive predictive value up to 99%. So with the same sensitivity and specificity, when you look at the test results, you have to take into consideration whether the person is likely to have the test before it starts. Now, we all do this in clinical practice on a day-to-day basis without actually realizing it. Say, for example, you have a 40-year-old female with funny chest pain without any risk factors. You'd say she's unlikely to have the coronary artery disease, so a low pre-test probability. So if you did a test on her and got a positive result, you'd say, well, this is a bit funny. I might be a false positive result. On the other hand, if you have a 70-year-old male with typical angina who's also a smoker and diabetic, he has a fairly high probability of having the disease. So if you've got a negative test on him, you say, well, I'm not 100% sure that this is actually, this might be a false negative. So basically the results you have to interpret in the light of the pretest probability or the prevalence. So the results for myocardial perfusion imaging depends on the studies that you've done, the reports in the literature, but the sensitivity is 80 to 90% and the specificity is 70 to 80%. Now, because there is a relatively low prevalence of coronary artery disease in the community, taking into consideration what was on the previous slide, if the person has a negative scan, that has a very good negative predictive value. So the figures that have been used are that having a risk of an infarct or cardiac death is only about 0.5% per year after that, or of unstable angina or revascularization is about 1.2% per year. So overall, you're seeing that if someone has a negative test overall, then that's a very good prognostic feature. So the first poll question, is a negative myocardial perfusion scan indicates good prognosis with respect to cardiac events. Is this true or false? So I would hope that most of you would have put down true in the light of what was on the previous slide. I'll show you some pictures now so that you know what we actually are looking at. So this is a normal study. The pictures on the top here are the stress study, and on the bottom is the rest study. Now, we look at these. This one is called the short axis view, or the cucumber slices, for obvious reasons. This one is called the vertical long axis, and this one is called the horizontal long axis. And what you can see here, these are cuts through the heart from the apex through to the base. And this is the anterior wall, that is the lateral or posterior wall, the inferior wall, and the septum. And if we cut through this way, we have the anterior wall, the apex, and the inferior wall. And if we cut through this way, we have the septum, apex, and lateral wall. If we then take these slices and lay them on top of each other, as if like peeling an orange and laying the skin flat, you basically have the 3 dimensions become 2. So on the short axis slices, you lay each cucumber slice on the one below and you end up with a 2-dimensional picture. So we have apex here, base here, anterior wall, lateral, posterior wall, inferior wall, and septum. And you can see how this divides up the coronary artery territories. This is the left anterior descending coronary artery territory, left circumflex coronary artery territory, and right coronary artery territory. So you can see here, overall, it's fairly uniform colour throughout. So these are a normal stress and a normal rest study. We can also, using the clever computer techniques, calculate an ejection fraction. And we can see here that on this study, it's calculated at 83%. and it also can calculate the diastolic and systolic volumes, which can be handy in some situations. What I'm going to show you here is a reversible defect. So here you have a hole in the cucumber or the donut. This bit here has got reduced uptake, you can see, compared with the rest on the stress study, and on the rest study, it completely normalizes. You can see here, septum is okay, lateral wall, infralateral wall is reduced, and then it returns to normal on the rest study. So this is ischemia in the infralateral wall. And on our polar map, we can see there's a big hole here in this part, which is the left circumflex coronary artery territory. So that's probably a proximal left circumflex coronary artery territory stenosis. Here we have what's called a partially reversible defect. So it's probably best to look at these slices here. You can see on the stress study, there's a big defect here at the apex, quite severe. And on the rest study, it's improved, but it hasn't entirely normalized. You sort of see it here to an extent. There's a bit of a defect, hasn't entirely normalized further towards the apex. So what this means is there's probably infarct plus peri-infarctional ischemia, and it's in the distal anterolateral wall and apex. And you can see here, there's a quite dark defect in the apex, which becomes a little bit paler on the rest study. And this area here also disappears. So there's probably an apical infarct with some peri-infarctional ischemia in the distal LAD coronary artery territory. Here we have what we call a fixed defect. So once again, you probably see it better on these images. See a big hole here on the stress, no change on the rest. Big hole on the stress, no change on the rest. Hole here, no significant change on the rest. So that's a big anterior and lateral fixed defect. And you can see on the polar map here, there's a big hole here in the LAD and left circumflex coronary artery territories, and it doesn't really change. So that's, and also if you look up here, you can see in tiny print, that's the ejection fraction of 25%, and these end diastolic and end systolic volumes are significantly increased. So this is someone with previous extensive infarction and an ischemic cardiomyopathy. So the second poll question is: a positive myocardial perfusion scan can differentiate between ischemia and infarction, true or false? And once again, on the basis of the previous couple of slides, I think I would hope that you've said that this is true. You can differentiate between ischemia and infarction using a myocardial perfusion scan. So that's the end of my presentation. Thank you very much.
Thanks, Rick, so much for that presentation. I'm sure a lot of us haven't heard so much detail about that investigation, and it's very informative for us. Now we have time for answering some questions which a lot of our participants have posted, and I'll do my best to ask most of them of our presenters. If we don't get time to answer them all, there'll be an effort made to get these questions answered and responses posted on the IMED website in the coming week or so. So just starting back with some simple questions, I think first, which are very relevant. I think first of all, probably relevant for Peter, Penelope asks, she's not sure of the benefit of standard echo over stress echo. Can you assist with that?
Yeah, thanks, Penelope, for your question. Basically, a normal echo is looking at the left ventricular wall, the ejection fraction, if there's a previous infarct, if there's any valvular heart disease, pericardial disease. It's a static test. A stress echo is a functional test which is trying to assess whether there is a coronary stenosis. So the resting echo, the patient would be lying still. The stress echo, the patient would have an echo before. And as I mentioned in my talk, we would look at the different left ventricular areas. Then you would stress the patient, do similar views, and see if there's a difference in left ventricular function pre-test and post-test. So very different tests looking for very different diseases or problems with the heart.
Okay, thanks. Now, there's quite a few questions, probably directed to Peter, concerning calcium scoring and CT coronary angiogram, and I'm happy to recommend going to the IMED website and looking at the previous webinar, which went into this in detail. And some of the questions include, is CT coronary angiography done for an asymptomatic patient with risk factors and family history?
Well, it's a very good question, and there's been a lot of debate about it. Just to say up front, in Australia, you cannot get a Medicare rebate for a patient who's asymptomatic. But I still believe that in a patient with risk factors at the right age, even if asymptomatic, it is a good upfront test to categorically exclude any evidence of coronary disease. And that's why I mentioned so often subclinical atherosclerosis. That CT angiography, even in an asymptomatic patient, could alert you to significant coronary disease with a high calcium score, which would be completely missed on a stress echo. So I still believe as a screening test for someone with risk factors, it is a good upfront test. The drawbacks are the radiation, as Rick mentioned in his talk. Radiation, although coming down, is one of the drawbacks of a full CT coronary angiogram. And also there is a very small risk of contrast reaction or allergy. But besides that, I think it is a very good upfront test in an asymptomatic patient, bearing in mind there's no Medicare rebate.
Thank you. Now, also to you, Peter, Robert asks, he says, I understand there's no documented prognostic benefit to CT coronary angiography over calcium scoring in asymptomatic patients, despite the extra cost and radiation. What are your comments?
I agree with that. There is no prognostic or trial that I know of. There's been a lot of data on calcium scores, but there is not a lot of data on CT angiography alone and its prognostic implications. However, we do see patients with zero calcium score, with soft plaque, which could be in the proximal LAD, could be in the left main, which is missed if you do only a calcium score. This is a rare occurrence, but does occur. But you're right in saying the data is far stronger for calcium scores in the population and prognosis, and not much added benefit prognostically for CT angiography.
Thank you. Now, Rick, one question for you is, probably you to answer as, and maybe Peter if you want, is what sort of time is involved in having these tests done for the patient? How long do they take to have these investigations?
Thanks, Philip. The injection obviously doesn't take too long. The first scan takes about 30 minutes. The stress test takes hooking up the ECG and the like. If you add that all in, that takes about half an hour. Then you have the injection and about 15 minutes for the second part of the scan. If they're done on the same day, there has to be a gap between them, but quite often, and sometimes it's worthwhile because it will reduce the dose of radiation a little bit, we do them on separate days.
So all up, you're looking at 2 to 3 hours, or if it's done on the same day, a bit longer.
Okay. And the other question related probably for Peter is that Gong asks, what do you think is a suitable age for calcium score? And if someone's had a normal ECG and troponin, should they have a CT coronary angiogram if the doctor suspects ischemia? And then he comments that there's no MBS funding for them for GPs to order it, or should it be better to order calcium score than a stress echo? So I'm not sure what you guys think of that.
Okay, well, Rick, do you want to go?
I'll leave that one up to you, Peter. I'll leave that the CTCA and coronary score to you.
Look, I think as with anything in medicine, it's a case-by-case basis, and it's a discussion that we need to have with each patient individually. I think that a calcium score and a stress echo gives you a lot of information with very little radiation and very little risk. And the CT coronary angiogram, we can't give to all patients. So, however, I need to back that up by saying if a patient comes into the hospital with chest pain and a negative troponin, that doesn't exclude coronary disease. That means that the patient is unlikely to have an acute coronary syndrome, provided the ECG is normal. Then you've got to take into account, as Rick mentioned earlier, the pre-test probability. If you still think that this chest pain was typical ischemic-like chest pain, and there are a number of risk factors, then I think the patient does need to have another test. Now, that could be a stress echo and calcium score, or you could go down the route of a CT coronary angiogram. But just the presentation with a normal troponin, normal ECG, does not exclude coronary disease. And that is why in these high-risk patients, before they leave the hospital, they either have a functional test with good prognostic implications, or have an outpatient CTCA, which would be a little bit more conclusive. But we need to go on a case-by-case basis.
Thanks, Peter. This is probably also for you too. Kelly asks, as a GP, we're taught CT coronary angiography should be left for the cardiologist to order regarding the cost to the patient. Could the cardiologist comment on this?
Well, if the patient fulfills the criteria for CT coronary angiography, meaning they need to have typical chest pain or shortness of breath on exertion with a number of risk factors making them intermediate risk, then referring them to a cardiologist, they would be able to get a Medicare rebate. If the GP suspects coronary disease and the patient is asymptomatic, then the patient has to pay for the test. So it's really up to the GP and in a discussion with the patient, do they want to go to the cardiologist, just to save money and to get the Medicare rebate, or they pay for the test themselves, then they don't have to go to the cardiologist. This has to be put to the patient.
Okay, thank you. Now, there's also a question from Zia asking, do we get calcium scoring as well when the GP requests a CT coronary angiography?
Okay, that's a good question. It depends on the site. Some sites do away with calcium scoring because it does add a little bit more radiation. But as far as I'm aware, and I know where I work at IMED in Sydney, we do calcium scores on all patients prior to the scan because it gives us a little bit more information of what dosage to use. when we do the CT coronary angiogram. Does give a lot of prognostic relevance. We don't do a calcium score in very young patients where you're looking for coronary anomalies, or patients under the age of 35. We don't do calcium scores, but otherwise everybody else who's presenting to diagnose or exclude coronary disease, I would say we do calcium scores in 95% or more.
Thank you. I think you probably answered this, Peter, but just to follow up, Asanja asks, are 40-plus males with moderate hypercholesterolemia with satisfactory exercise tolerance a good candidate for CT coronary angiography to assess the coronaries?
Look, a 45-year-old male with a number of risk factors, even though they are fit and well, asymptomatic, I don't think it would be a high priority of mine. If they were a smoker, diabetic, family history of premature coronary artery disease, it would move me to screen a little bit earlier. So again, as with all medicine, it's a case-by-case basis. If the brother or sister or father had a myocardial infarction at a young age, sure, 45-year-old would be considered for a screening test.
Thanks. Now, what about the calcium? What about the radiation exposure on just calcium scoring only? How many chest X-ray worth is that?
Yeah, I'm not sure of the exact number, but calcium scoring alone, I think it would be between 5 and 10 standard chest X-rays, but don't quote me on that. I'm not a radiologist, and I don't know the definite answer to that.
Okay. Now, someone asked a good question. Do you see us moving away from doing an ECG and a chest X-ray as a first step in someone we're considering ischemic heart disease?
I think that would be a bad mistake. I think history, ECG, chest X-ray, and a good clinical examination is vital in all patients that we assess. And I'll give you an example. I had a patient not so long ago who was referred for a cardiac checkup. They'd had an echo at another practice, put your stethoscope on the chest, had this loud radiating murmur, and it turned out the patient had coarctation of the aorta, completely outside the cardiac frame of an echocardiogram in most situations. But the loud radiating murmur prompted the echo technician to spend a little bit more time on the aorta, the descending aorta, and found a critical coarctation. And I'm sure Rick would bear me out. There's no substitute for basic clinical medicine, blood pressure recording, stethoscope, and an ECG can give you a lot of information that could be missed. For example, Brugada's syndrome, an abnormal ECG could make you worry about hypertrophic cardiomyopathy, about cardiomyopathy. It gives a lot of added benefit. For right heart disease, there's a lot of benefit of sticking to the old traditional testing, etc.
I think
Agreed entirely.
time's caught up with us again, and thanks, Rick. I think time's caught up with us again, and I really want to thank both our presenters, Rick and Peter, for their detailed and informative presentations and the answering of the questions that have been posed. And I also want to thank all our participants for posing those questions and being part of this webinar. So I'd like to say thanks and good night to everyone, and I'll hand you back now to Rick Hoffman for some final concluding remarks.
Thank you for that. And thanks, Professor McLean and Dr. Bortz, for the really informative presentation tonight. I'd also like to thank Dr. Perlstein for facilitating and also for our audience for joining us tonight. We do look forward to your feedback, so can I please ask that you stay online where you'll be redirected to complete an evaluation of tonight's presentation. Once again, thank you and good night.